warahmatullahi wabarakatuh. I bid to Dr. Rohayu, Dr. Fairuz, and also my fellow friends. My name is Hadirah. Today I'll be presenting basic life support supervised by Dr. Rohayu. So basic life support included the airway, breathing, circulation, use of the automated external defibrillator, and also management of the choking. First, we go to the change of the survival. For the change of survival, we divide it into inpatient and also outpatient. For the inpatient, we have first one is early recognition and also prevention. Second, activation of emergency response. Third, high quality CPR. Fourth, defibrillator. Fifth is the post cardiac arrest care and also recovery. For the outpatient, activation of emergency response, high quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest care, and also recovery. Recovery is the sixth link added to the change of the survival. Usually, the patient after cardiac arrest, the care will be continued long after initial hospitalization. So, this patient should have performer assessment and also support for their physical, cognitive, and also psychosocial needs. So during CPR, what will happen to the heart? So when we do the external chest compression, the blood will be pushed out of the heart chamber. Thus, we'll be maintaining the blood flow and also oxygen delivery to the vital organ. So maximum chest compression is about 120 compression per minute, and we must allow adequate chest recoil. So when the chest full recoil, this will enable the adequate perfusion to the heart muscle and the blood to fill the heart chamber during the diastole. During the cardiac arrest, usually the body metabolic demands for the oxygen will be decreased. Therefore, only small amount of air needed for ventilation. We must avoid overventilation as it will decrease the ventricle and also atrial filling, decrease the coronary perfusion, distension of the stomach leading to regurgitation and also aspiration. So what is sudden cardiac arrest? Sudden cardiac arrest is a condition where the heart suddenly unexpectedly stops beating due to the blood stop flow to the brain and also other vital organs. This can be seen by the patient presenting with abnormal or absent breathing, no pulse, unresponsive, absent signs of life such as cough or movement. If the patient in cardiac arrest, this can cause death if not treated immediately. For the adult, usually most common causes is the cardiac. For every minute, if the patient in cardiac arrest without receiving the CPR and also defibrillator use, their chance of survival will be decreased about 10%. So for the adult basic life support, first we have the initial assessment. For the initial assessment, first we must ensure that the surrounding is safe. Second, we check for the response of the victim by tapping the shoulder, ask, sir, are you okay? And then shout for help. Open the airway by head tilting lift, or if there is cervical injury, we can perform the jaw thrust. Assess for the breathing, not more than 10 seconds. And then do the chest compression if the patient unresponsive or no pulse felt. There is a criteria for the high quality chest compression. Usually we do in the middle of the chest at the lower half of the sternum. The depth is about 2 inch. The rate is about 100 to 120 compression per minute, and allow the chest to recoil after each compression. Minimize interruption less than 10 seconds, and do the compression about 30 compression to 2 ventilation, and then assess the need for the shock when the AED arrives. So for the adult basic life support algorithm, first we verify the scene safety, check the response, shout for the help, activate the emergency response, and also get someone else to bring the AED. And then we look for the pulse and breathing. If the patient is breathing normal and the pulse is felt, we monitor until the emergency respondent arrives. If the patient not breathing normal, but the pulse is felt, we can give rescue breath, about 10 breaths per minute or 1 breath every 6 seconds. And then we check the pulse every 2 minutes. If no pulse, we can start CPR. If there is no breathing or only gasping and no pulse felt, we start the CPR about 30 compression to 2 breaths, and use of AED if it's available. When the AED arrives, we check the rhythm whether it's shockable or non-shockable. If it is shockable, we can give shock and resume CPR immediately for 2 minutes. And then we continue until the advanced life support take over. If it is non-shockable, we resume CPR for 2 minutes until advanced life support arrives. So first for the circulation, for the chest compression, first we place one heel of one hand to the center of the victim chest, and then we place another heel of hand on top of the first hand. We interlock the finger, and then ensure that the pressure is not applied over the victim rib. Keep your arms straight and do chest compression. So for the airway, we can do head tilt chin lift or jaw thrust. For the head tilt chin lift, we place the hand on the forehead and gently tilt the head back. Put your fingertip on the chin and lift the chin to open the airway. Or in the suspected cervical injury, we can use index and also middle finger to push the postural aspect of mandible upward, while the thumb used to push down the chin to open the mouth. For the breathing, we can look for the chest rise. Listen to the breath sound, whether it's normal or abnormal. Feel the air on your cheek. If the breathing is abnormal but the pulse is fell, we can give rescue breath 1 in 6 seconds or 10 breaths per minute and then check the pulse every 2 minutes. If no pulse, we can do CPR. So for the rescue breath, we have 3 types. If there is ambu bag present, we can use back valve ventilation. If not present, we can do mouth-to-mouth ventilation or mouth-to-mouth rescue breath. When there is need for the shock, so we attach the AED pad to the chest, right upper chest and also left lower. We attach the pad on the victim bare chest. If more than one healthcare worker is present, CPR should be continued while the pad being attached to the chest, and then we follow the instruction. If the shock is advised, we can deliver the shock within the 5 seconds and ensure that nobody is touching the victim. With a clear chant, I am clear, you are clear, everyone is clear, and then push the shock button. Immediately restart CPR with the compression 30 to 2 ventilation and continue as directed by voice or visual prompt. Is no shock advised, continue CPR. And then after CPR, every 5 cycles or 2 minutes of CPR, we should check for normal breathing. Do not stop resuscitation until the victim recovers with normal breathing. Healthcare personnel is exhausted or assistant arrive to take over. So when do we terminate the basic life support? We terminate basic life support when the arrest is not witnessed by the emergency medical personnel, no return of spontaneous circulation, no AED shock delivered before the transport. If all 3 criteria present, consider termination of resuscitation. If any of criteria is missing, continue resuscitation and transport. For the recovery, this is the picture showing the recovery position. We place the arm nearest to you at the right angle to his body, the elbow bent with the hand palm out, and bring the far arm across the chest and hold the back of the hand against victim cheek nearest to you. With another hand, grasp the far leg above the knee and pull. Keep the foot on the ground, keep hand pressed against cheek to pull on the far leg to roll the victim towards you to his side. Adjust the upper leg so that the both hip and knee are bent at the right angle. And if necessary, use hand under the cheek to keep the head tilt face downward to allow liquid material to be drained. So what are the signs that the patient is recovered? Usually patient will be waking up, moving, open eye or have normal breathing. So for the pediatric, usually
Hadirah, sebelum proceed pada pediatric, saya komen sikit lah. Okay, so basically untuk healthcare punya DRSABC kan, dia punya mnemonik dia lah kan, semua kena tahu BLS. BLS is very important. Tapi kalau you buat teaching, kata you buat teaching untuk public kan, mengajak public, selalunya kita tak ajak check pass lah, yang tu beza, tak check pass. Lepas tu kalau yang untuk bagi airway, open airway, yes, kalau kata you bagi mouth to mouth breathing, sekarang ni kita tak advise lah untuk bagi kan. So selalunya kalau yang tu dia continue CPR je lah. Kecuali yang tu relative terdekat, yes kan, relative terdekat, yes. Tapi check pulse tu memang untuk kita ajak layman person, memang kita tak check pulse. Lepas tu the other thing adalah kalau kata ambulance call, okay, kita punya paramedic dia respond to ambulance call, dia pergi ke rumah. So kalau kata dia dah pronounce death, no problem. So tak payah bawa patient datang hospital lah. Okay, just kita kata testify kata yang ni patient ni dah tak ada, dah pass away, dah tak ada. Okay, tapi kalau kata once they start the resuscitation, lepas start CPR, dapat tak dapat, is a must untuk bawa balik patient. Okay, is a must untuk bawa balik patient ke hospital. Okay, kena bawa balik hospital dah start CPR. Yang tu rules dia. Okay. Biasa dengar code blue?
Biasa.
Biasa. Apa yang you faham mengenai code blue?
Masa bila orang panggil code blue ni?
Masa bila
yang
bila
biasa awak dengar code blue ni? Sebab biasa kan? So masa bila? Kawan-kawan pun boleh tolong kalau you know.
Saya kat Hadirah nak jawab seorang-seorang.
So kata biasa dengar code blue kan. So masa bila biasa code blue ni?
Kalau patient goes into cardiac arrest ataupun any respiratory distress ke.
Where? I mean kalau patient korang kat medical ward kan, patient arrested dalam medical ward, korang activate code blue ke?
Tak.
Nah, so masa bila nak activate code blue? Kat kecemasan, patient collapse, kat red zone, code blue ke?
Kalau dia duduk pedalaman, doktor? Ke
Kalau
kawasan
duduk
yang jauh dari hospital?
pedalaman. So kalau patient duduk kat kota Sungai Kinabatangan tu, dia collapse, activate code blue lah. Sampai kat kita lah code blue dia tu. Duduk post Pasik ke dekat code blue. Pernah dengar kat hospital kan, kadang-kadang dia announce code blue dekat sekian-sekian. Perasan tak? Pernah dengar tak? I mean zaman COVID ni kurang sikit. Hadirah biasa dengar kat mana code blue?
Betul, tak boleh fikir.
Tak boleh fikir. Code blue ni merujuk kepada bila berlaku patient cardiac arrest ataupun patient tidak sedarkan diri dalam hospital tapi bukan dalam ward. Maksudnya mungkin pelawat, pesakit yang datang ke MOPD, SOPD, duduk ruang menunggu, tunggu nak ambil ubat farmasi. For some reason, patient to become unresponsive or collapse. That's when code blue is activated lah. So code blue ni is for potential cardiac arrest dalam hospital. Tapi di luar, maksudnya bukan dalam ward ataupun bukan di kawasan macam klinik, bukan kecemasan apa semualah. Lebih kepada either staff or visitor or pelawat dan sebagainya lah. So pesakit-pesakit yang orang-orang yang di kawasan ni tak ada orang akan claim sebagai patient depa kan. Patient pergi kafe, collapse. Siapa yang patut respon? Medical ke? Surgical ke? Faham? So maksudnya these are the kind of patient yang they still need treatment. Or they arrested. Tapi somebody need to take charge lah. So that's why code blue is activated. Code blue ni untuk, tapi code blue ni awak kena faham juga. Primary responder is the one yang witness kejadian tu lah. Okay, because of COVID ni, kita kalau kita hospital HSAH ada sistem code blue. And kita dah assign lah certain kawasan. Primary responder dia adalah siapa-siapa. Usually orang yang dekat lah. Say kalau patient collapse dekat kafe ke, sepatutnya primary responder tu adalah daripada radiologi lah. Because radiologi dengan kafe kan dekat. So the role of primary responder ni adalah untuk start basic life support. Kalau per-issue belum CPR is to start CPR. So bila kata code blue is activated, that's why code blue ni dia akan announce dekat PA system hospital. Code blue di cafeteria. So siapa yang cover kawasan cafeteria tu sepatutnya akan pergi respon lah. So primary responder ni should arrive within less than 4 minutes untuk initiate CPR apa semua. And then the secondary responder ni biasanya daripada kita punya pre-hospital care team, kita punya ambulance team. Ni yang team yang akan datang dengan AED or dengan stretcher dan sebagainya. This is the advanced life support punya team lah. So cuma dah sejak COVID ni dia kurang sikit sebab satu PHC kita pun dah pindah-pindah dan yang kedua kita patient pun tak ramai kan. So jarang awak dengar code blue. Cuma isunya code blue ni kadang-kadang disalahgunakan. Code blue ni is meant for patient yang become unconscious or cardiac arrest. It's not meant for visitor tiba-tiba pening-pening kepala kat MOPD ataupun sementara tunggu kat farmasi jadi mengantuk ke. It's not meant for that. Code blue ni is meant for patient yang arrested. Patient yang bukan inpatient, yang arrested dalam kawasan hospital. Dalam kawasan hospital sahaja. Faham? So itu code blue-nya. So janganlah kalau patient kat klinik ambil darah lepas tu macam pitam code blue. That's not code blue. Itu attend je lah. Code blue ni is meant for patient yang cardiac arrest or unconscious.
Saya cuma nak tambah sikit yang kalau selalu nak initiate yang CPR apa semua kan, salah satu kalau patient unresponsive memang boleh pick up kan. Patient no breathing pun boleh pick up kan, cuma abnormal breathing tu kadang dia tengah gasping okay lah. Kalau you tengok yang kriteria kita nak start resuscitate patient tu no breathing ataupun abnormal breathing. So kalau you nampak abnormal breathing tu, you check lah pulse. Kalau pulse ada tu, initiate CPR tu kan. Kerana patient dengan gasping kan, dia consider abnormal breathing tu, selalunya orang termiss out dah tu. Okay. Okay, Hadirah boleh sambung pediatric BLS kan.
Okay. For the pediatric group, the most majority of the pediatric cardiorespiratory arrest usually occur due to the respiratory insufficiency. So ventilation is very important in children. For the children, we still use the mnemonic DRS ABCD. First, we check for the danger, ensure that the scene is safe. Second, we check the response by stimulate the child, or if the infant, we can tap the foot. And then we can shout for help, open the airway by hip tail chin lift. Assess for the normal breathing, not more than 10 seconds. If no breathing or abnormal breathing gasp is seen, give 5 rescue breaths. And then for the circulation, in less than 10 seconds, we must look for the sign of life. Check the pulse. Usually for the children, we check dia punya pulse tu, kalau children dekat carotid dengan femoral. Tapi kalau infant dekat brachial dengan femoral. And then start the chest compression if pulse less than 16 beat per minute with poor perfusion. And the high quality CPR, previous we used 15 to 2 in children, but now if one healthcare provider 30 to 2, if two healthcare provider 15 to 2, and then assess the need for the shock. So for the pediatric basic life support for single rescuer, first we verify the scene safety, check for the response, shock for the nearby hub, activate the emergency response. If no breathing or only gasping, and check for the pulse simultaneously. If definitely fell within 10 seconds and normal breathing, monitor the patient. If no normal breathing but the pulse is fell, give rescue breath, 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Assess the pulse not more than 10 seconds. If heart rate less than 60 beats per minute with poor perfusion, we start CPR. If no, we continue the rescue breath and check the pulse every 2 minutes. If no pulse, we start CPR. And then when one rescue, perform the CPR 30 compression to 2 breath. When second rescue arrive, perform the 15 side compression to 2 breath. And after 2 minutes, if still alone, we activate the emergency response and retrieve the AED is not done yet. And then we check the rhythm whether it's shockable or non-shockable. If it is shockable, we can give one shot and resume CPR immediately for 2 minutes and continue until the advanced life support provider take over. If non-shockable, we resume CPR immediately for 2 minutes and continue until the advanced life support provider take over. For the two rescuer is same, but the difference only on the cycle of 15 to 2. If 1, 30 to 2. So for the circulation, for the children, as I said earlier, we can check at the carotid on femoral. For the infant, we check at the brachial and also femoral. In less than 10 seconds, we check for the sign of life by movement, cough, or normal breathing. Feel the pulsation over the carotid femoral for the children, brachial femoral for the infant. Start CPR if absent or animal breathing, heart rate less than 60 beats per minute with full perfusion. For the airway, in children, we can put in sniffing position, or if there is cervical injury, we can do jaw thrust. For the infant, put in neutral position. For the breathing, we use the loop listen field technique, and then we look for the chest rise. Listen to the breath sound, whether it's normal or abnormal. Feel the air on your cheek. If the infant or children breath normal, put in recovery position. If the infant or child breathing not normal but the pulse is fell, we can give rescue breath 1 every 2 to 3 seconds or 20 to 30 breaths per minute. So for the defibrillator, we assess the need for the shock, and then we attach the AED or manual defibrillator and do not interrupt the chest compression. Follow the AED from device. Usually for the children aged 1 to 8 years old, usually special pediatric pad should be used for children 1 to 8 years old. In situation when there is no AED with pediatric pad, we can use the adult pad. For the infant, usually it's better to use the manual defibrillator. If the infant less than 10 kilo, we can use 4.5 cm. If more than 10 kilo or older than 1 year, we can use 8 to 12 cm. The pad, we can apply children as same as adult, or we can use an anteroposterior position, back prime position. This is the picture showing the recovery position. For the child, we place the child in the true lateral position as possible to allow the drainage of the fluid from the mouth. Ensure that the position is stable. There should be no pressure on the chest that will impair the breathing. Turn the child to his side to return his back easily and safe, taking consideration of the cervical spine. Ensure that the airway is accessible and easily observed. The adult recovery position usually suitable for the children, but for the infant, we can put in the picture like this. For the EED, so this is the picture of EED. So early defibrillator is the key link for the change of survival. 80 to 90% of the cardiac arrest usually occur due to ventricular fibrillation or pulseless ventricular tachycardia. Usually, survival rate will decrease 7 to 10% each minute without CPR or defibrillator. If CPR only done, the survival rate only about 3 to 5%. If combination of CPR and also defibrillator use, the survival rate will increase up to 30 to 70%. So this is the example of the situation where the pad will be difficult to be attached when there is hairy chest. So it's advised to shave the area of the pad placement. If the patient is drawn, usually we use towel to wipe the patient first, remove from the water to attach the pad, as water is a good conductor of electricity and will hinder the delivery of adequate dose of shock. If the patient is on implantable defibrillator or pacemaker, usually you avoid AED placement over the pacemaker. If implant cardiac device deliver shock, allow 30 to 60 seconds prior to deliver shock by AED. If the patient use transdermal medication pad, do not place AED on top of the transdermal pad. We remove the pad, wipe the area before use external defibrillator. So next is management of the choking. Tu nak continue ke?
Continue, tak apa.
Saya nak tanya, untuk defibrillator, machine kita biasa kan? Machine defibrillator tu ada yang untuk defib untuk pediatric patient.
Kita ada defibrillator khas tak untuk pediatrik?
Hadirah ke siapa nak jawab, no problem.
Saya tak pernah tengok doktor.
Tak pernah tanya?
Tak tahu.
Ada siapa-siapa
Nampak
tahu?
je kan? So kalau you all tahu yang pedal tu dia boleh remove tau. Biasa tengok tak orang remove, tak bisa kan? Dia boleh remove, lepas tu dia akan ada yang kecil.
Pedal kecil.
Itu soalan dia, soalan yang lebih
Nanti saja-saja kat red zone
ada
tu.
tak defibrillation khas?
Saja-saja kat red zone tu pergilah pegang defibrillator tu and tengok pedal dia. Actually some boleh buka pedal dia jadikan kecil.
Adjust on body weight dia lah, 4 joule per kg tu. Silap 4 joule per kg. So depends on body size. Tapi most of the children, kalau dia patient collapse ke apa, selalunya due to hypoxic kan. Selalunya akan ya event ni kan. Tapi dia memang yang dia tu memang dia design you boleh tolak dan dapat yang pitch punya pedal, pitch punya size. So you adjust dia punya joule tu accordingly to dia punya body weight lah. Okay. Okay kan last kan? Boleh sambung ke? Tetap saya.
Okay. Next, I'll be presenting management of the choking. For the choking, usually there are a few universal signs of the choking. First, both hands will be wrapped around the base of the throat. In complete airway obstruction, usually the patient is unable to speak, cry, or provide any respiration. For the partial obstruction, usually may result in stridor, high-pitched audible voice, or may produce productive cough and allow the patient to speak. So, this is an example of the patient who has risk of the choking. For example, those who have reduced consciousness, those who are on alcohol or drug intoxication, those who have stroke or Parkinson's disease, those who have respiratory disease, dementia, poor dentition, and also old age. So for the severity, first we assess the severity of the choking, whether it's mild or severe. If it is mild, we can encourage the patient to cough. Continue to check for deterioration to ineffective cough until the obstruction is relieved. If the obstruction is severe, we check whether the patient conscious or not. If the patient conscious, we can give 5 back blow like in the picture, or we can do the abdominal thrust. If the patient unconscious, we can do CPR. So management for the choking in adult. First, we suspect the choking, encourage the patient to cough. We can give 5 back blow or 5 abdominal thrust and start CPR. So how to do the abdominal thrust? First, we clench your fist and place it between the umbilical and also the rib cage. grasp this hand with your another hand and push sharply inward and also upward. Repeat 5 times. If obstruction is still not relieved, we can alternate 5 back blow and also 5 abdominal thrust. So as you open the airway to give the ventilation, look for the patient mouth for any visible object. If you can see the object, we remove the object by using finger sweep motion. If you don't see the object, do not perform a blind finger swipe but continue the CPR. Remember to never try more than 2 ventilation during one cycle of CPR, even if the chest do not rise. After 30 compression, attempt to rescue breath in unconscious patient, and then continue CPR until the victim recover or start breathing normally. So this is the pediatric general sign of choking. First, we have someone witness the episode. The patient cough or choking, sudden onset. We have history of playing or eating small object. If the patient can cough, encourage cough. Usually this patient will be presenting with crying, loud cough, but able to take breath before cough. Patient usually fully respond. If the ineffective cough, usually patient will be quiet, silent cough, or sometimes can appear sinus and decreased level of consciousness. So this for the children are more similar like the adult one. So this is the management of the choking. First, for the infant, 5 back blow in the infant. You can support the infant by head downward in the prone position. The rescuers will be sit or kneeling rescuer will support the infant. Infant support the head by placing the thumb of one hand at the angle of lower jaw and another 2 hands of similar hand on another side of jaw. And then we deliver sharp 5 back blow. For the infant, usually we do not do the abdominal thrust. We can do the chest thrust. Deliver 5 chest thrust, usually similar to chest compression but sharper and deliver at slower rate. For the children, we can put in the position like in the picture. If not possible, we can support forward leaning and deliver 5 back blow. But for the children, we can do the abdominal thrust. Stand or kneel behind the patient and deliver the abdominal thrust. So this is the comparison for the adult, children and also infant. The CPR sequence is similar, DRS, ABCD. The compression also similar, 100 to 120 compression per minute. The depth for the adult about 5 cm but not more than 6 cm. For the children, 1/3 of the depth of chest of 5 cm. For the infant, at least 1/3 of the depth of chest of 4 cm, and we must allow complete recoil after each compression. Minimize interruption less than 10 seconds. For the ratio for the adult, 30 to 2, compression to ventilation. For the children and infant, if one healthcare rescuer, 30 to 2. If 2 healthcare rescuer, 15 to 2. For ventilation in adult, 1 breath every 6 seconds, about 10 breaths per minute. For the children and infant, 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. And then defibrillator, that's all. Itu saya dah habis.
Okay. Okay, so basic life support So basic life support ni semua orang kena tahulah. Especially bila anda memakai white coat di dalam hospital ni, people expect you to be able to do miracles lah. Okay, so the reason why kita stress on basic life support ni, because basic life support ni sebenarnya dia penting. Basic life support is something that we teach public pun. Tapi bila benda ni kita ajar kat public punya expectation and orang kita punya expectation pun, you as healthcare professional ni is very proficient lah in basic life support. So apa yang saya cakap, bila dalam konteks kalau contohnya patient collapse kat cafe kan, ramai kan orang ber-white coat semua kat cafe kan. Tak kira lah pharmacy ke housemen ke, housemen dengan pharmacy je pakai white coat ni. So katalah patient collapse dekat cafeteria, And none of the orang yang pakai white coat ni, step forward nak buat basic life support. Dia jadi macam pelik kan. Dia jadi macam tak sepatutnya berlaku lah. So that's why you as healthcare professional, as doctors, especially yang duduk kat kecemasan ni, basic life support ni should be level macam spinal reflex je. Nampak patient collapse je, DRABC D je. Okay. Sebab part of basic life support pun sekarang kita dah ajar AED to the public. So korang yang duduk kat hospital ni, yang kerja dekat hospital ni, should be very proficient with your basic life support. Tak ada kompromi lah. This is something yang kita ajar dekat St. John's, PBSM, budak-budak sekolah, Form 3, Form 5. So, and diorang berani buat. So, korang kena proficient lah. Kat mall ke, kat cafe ke, kat MOPD, kat SOPD, if patient collapse, you know what to do. At least the initial step. Jangan semua orang lari, lepas tu panggil code blue, lepas tu biar patient tersadai kat situ kan. Because this happens. Okay? So, walaupun tajuk tu simple je, basic life support, the issue is, you need to be confident with your basic life support. Kalau ada patient tiba-tiba collapse depan you, you need to be able to know what to do lah. Okay? Okay ke? Ke saya cakap seseorang?
Okay.
Saya jawab. Saya just nak share experience satu berjalan yang shocking kan. You all pernah dapat tak choking patient? Choking. So saya ada few patient yang dapat tercekik biji durian, tertelan daging apa semua kan. So usually macam tu lah kalau kata you try nak buat the basic life support tu kan. Buat abdominal thrust tak jalan, puk belakang semua tak jalan. So yang patient saya tu saya bagi sedation lah untuk remove. Tapi bila you decide untuk nak bagi sedation kat patient, so kalau you are the junior, please discuss with the alert senior one. Lepas tu dari tu you kena make sure tempat yang you nak buat prosedur tu, nak remove ke apa is complete. Dia ada resusc trolley apa semualah, airway semua complete. Baru you decide decide untuk buat lah. Tapi jangan decide lambat sangat. Sebab kalau decide lambat sangat, patient dah tertelan, tercekik kan. You buat lambat sangat lah sekali, end up daripada conscious jadi unconscious lah, CPR. Okay.
Sebut pasal patient tercekik ni, if you go to yang YouTube channel yang saya post korang punya CME ni, ada satu video yang ada patient choke on grape and kita luckily sempat lah ambil video, kita remove grape dia guna Magel's forceps. So if you just go to the YouTube channel ada lah. This one dia taklah truly choke, tapi tapi it's interesting watch lah. Okay, seterusnya siapa present?
Any question sebelum kita move to the next topic, next presentation? Hadirah dengan
Anida.
orang cik ni.